TopMedTalk.
Nick Majerison here. Welcome to TopMedTalk. And on today's TopMedTalk, we're going to have a piece taken from the 20th Current Controversies in Anesthesia and Perioperative Medicine Conference held in Dingle by EBPOM. Don't forget, of course, you want more details on this podcast. Full show notes are available on TopMedTalk.com. Have a listen.
So it's a great pleasure to welcome our next speaker, Saul Aronson, who's a professor of anesthesiology from Duke, as it must be pronounced, where he's also executive vice chairman. He's also the lead for EBPOM USA, so he's very well placed to give us a picture on perioperative medicine from the US standpoint. Welcome, Saul.
Really a pleasure to be here. For those of you who have heard this lecture before, I apologize. For those of you who have not, I apologize. Dingle has been a really great experience. Mike woke me up about 5 minutes ago, for the record. So I would like to shift gears a little bit and talk to you about what's going on in the States. And as you probably have appreciated, we're new at this. We're the least mature of all the countries that are giving examples this morning. And I'm going to begin by sort of setting the framework of what life is like right now in healthcare in the United States. And I think this is a really clever quote by Bill Gates. It said, "Success is a lousy teacher. It seduces smart people into thinking they can't lose." We are all smart. We are all well-intended. We all have essentially the same goals, but we've been victims of our own success in the United States for a long time. And I think those chickens are coming home to roost right now because we're going through some very, very intense, very, very rapid, transformative changes in the industry of healthcare in the United States. And I would just say that as a backdrop and then focus how that applies to those of us who practice in the space of perioperative medicine. Few graphs. You've seen these all before. Certainly if you are from the United States, I know you have. But I just want to put it in perspective because I think it is important to calibrate. The rate of spend in the United States with respect to healthcare has outpaced the inflationary rate in general, so that we're right now spending close to 19% of our GDP. We've heard other speakers mention that probably $10,000 per patient per year, and that's equally true in the professional side as well as it is on the facility and farm side. And although we're moving so slowly from a volume, if you will, enterprise to a value one, and we are beginning to appreciate what life would be like when we give up fee-for-service, the reality is today the vast, vast majority of care in the United States is still a fee-for-service model. And so here we are. We know the train's coming. We know what we need to do, and yet it's so darn hard to give up that golden egg. And so it's like the wine, sell no wine before it's time. And so we're confronted with these administrators who and providers who are just latching on for every last second to see what we can squeeze out of that system. And there's just fundamental danger with that. The accountable care organizations are growing for sure, but it still is important that of our $3.5 trillion of spend in healthcare, the vast majority of that is still in a fee-for-service model. So perioperative medicine, we've heard this definition before, and I want to just sort of take that backdrop of the healthcare economics in general and focus it a little bit on perioperative medicine. Of course, we've seen this very clever definition from Mike before, but I also want to now sort of stand on that podium and soapbox and claim that for us to survive in the transformation of what we do as people who work and play and sort of spend our time thinking about that space is that we have to start to think like we are members, very, very integral members of the population health system. And so if you define, and there are many definitions, this is as good as any, population health is the health outcomes of a group of individuals, including the distribution of said outcomes within the group. And then almost in a Venn diagram way, overlap what we just saw as that definition of perioperative medicine. That's how I believe, especially in the States, we need to think about what we do. So that, in terms of sort of a pyramid structure, includes our attempt to enhance value by reducing costs and improving quality. And there are implementation guidelines that underscore that. We also, very, very important, have to be focused on the patient, of course. and also the provider. It's interesting that we're confronted right now with great problems with resilience and burnout and just drift away from very bright and smart people who are leaving medicine because it's becoming a hard job. And so I think again we have a duty and a burden to address that equally well, making things easy to do, not just the right thing to do. And if we can harness all that, then we would approach a population health sort of goal and enhance value. Because the reality is, whether you're in the UK, whether you're in Australia, or whether you're in the United States, whether you're in any country in the world, there just simply isn't enough money to take care of our healthcare needs. And so we have to enhance productivity. That's macroeconomics. We have to figure out how to enhance value. Doing more of the things that we've been doing is just simply unsustainable, and the bow will break. Again, another perspective slide. It's been guessed, debated that over the $3.5 or so trillion of spend for healthcare in the States, a significant percentage of that is just wasted for unnecessary or uncoordinated care. And if we could just improve our systems, even prior to understanding novel next horizon ideas or doing clever research, if we could just harness better our systems and processes, there's lots to be gained and more resources to do better things. And this is important to understand that this is true in perioperative medicine as much as it is, and I would argue even more so than in any other space in healthcare. It's an article that was published in the Wall Street Journal about a month ago, and it's fascinating. So, number one, it went to the lay public, and so this is something now that the consumer is reading and becoming much more appreciative of the state. Number two, it's just true. There's a clinic in northern Wisconsin called the Gunderson Clinic. It's a very famous clinic. And they did like a lean analysis. They did a Toyota-type lean analysis, and they wanted to understand what the real cost of doing a knee replacement was. Something as simple as what does it cost to replace a knee is a question that is incredibly complex in our complex healthcare systems. And they broke it down to every minute, every screw, every movement, just as if it was on an assembly line. And they learned that the cost of a knee in the States was about $7,000 to $10,000. The cost of a knee replacement has steadily increased over the years. You can see in that graph in the lower right there to north of $40,000. And so if you're a consumer and you're reading the newspaper, and there's flaws in the system for sure, that it should cost you $7,000 to get your knee replaced, and you get a bill from hospital X or Y or Z, and there's a facility cost of $40,000. There's going to be great pushback. There's going to be great tension in that consumerism-driven market. And in fact, we're beginning to see that now in the States as well. There's significant industries that are blowing up all the time over just transparency and data sharing and having the consumer be the driver of change. The free market is going to be the force, moreover than government or regulatory oversight, to change the healthcare system in our country. And we're seeing that very, very rapidly right now. Again, to help us reorient and focus on perioperative medicine, hospitalizations with surgeries make up just under 30% of all admissions, and yet they account for over 50% of the cost. And so I think that's really, and obviously it depends on the kind of site of surgery, but it's a very, very important statistic because we have a disproportionately important force to implement change in terms of that value proposition. The other thing that's important, these are some data that are a few years old now, but DMIC reported that if there's a complication as a consequence of surgery, an adverse event, on the average it's about a $12,000 hit on top of it. So how we do the procedure as efficiently as we can and to prevent or mitigate those adverse outcomes, very, very important. A couple months ago, I wrote an article with Mark McQuillan. For those of you who probably are unfamiliar, Mark led the CMS for a while under the Bush administration and is now the head of the Duke Health Policy Program. Very smart thought leader in the country, and we're really fortunate to have him at Duke. And in my population health role, I kind of knocked on his door and I tried to convince him that perioperative medicine was a really, really important contributor to the overall discussion of population health. And of course, he sort of dismissed it. It's such a small, after all, narrow sliver of that continuum of life that why should we focus on that few weeks or months of a patient's life when they have to have surgery? relative from birth to death when there's so much else to consider. And the argument I made, and I convinced him, which I think is the best result of the sort of interaction, is that though it does represent a very, very small sliver of the timeline of that continuum of life, it represents a disproportionately significant value proposition. The amount of money we spend in that very narrow time when people have surgery, in that immediate before, during, and after, is so much more money than they would spend proportionately with the rest of their care throughout life. And so it should make us feel that we have an incredibly important, not just something we should be tolerated for, but we have a duty, we have an incredibly important role in bending the curve because of what we do and what we can do. We saw some interesting data from Leland yesterday about how if you're 50 years old, you have a 50% chance to have one comorbidity, and if you're 65, you have a 65% chance of having multiple. Similar data in the States. By 2020, it's estimated that 50% of people will have at least one chronic comorbid disease, and 25% will have multiple comorbid disease. So our population is aging, it's getting sicker, and they're having surgery. And so our job then is to figure out how do you manage those patients. And I think the other interesting trend that's going on in the States right now is that there's a surge of retail industry to manage health care. Just yesterday I read CVS was bought, by Aetna, a large insurer in the States, for $69 billion. So there's great horizontal and vertical integration in the States whereby we're getting retailers into that space. People who are needing wellness are going to Walmart or Costco to get their health care. They're not going to see their doctors anymore. And I would argue that's brilliant. That makes sense. And so we have to really reorient what we provide and what we should provide in this sort of healthcare saga as well. I argue that there are 4 tranches of people in terms of the biologic cohort. There's most of us, or at least from a population health standpoint, who are healthy and really support the rest of our healthcare needs, and those are the people who are indeed going to be going to Target or Walmart or Costco to get their healthcare. And probably don't need to see physicians, and probably will see greater extender care to supply that service. And then there's the next tranche, which are people, I guess, like me, not necessarily because I'm hungover, but people like me who take their blood pressure medicine every day and take their lipid busters every day. And if you looked at me, you probably thought, my God, he looks so healthy. He can't be sick. He looks like he's an Olympic athlete or something. But I'm well managed. I do have chronic comorbid disease, but I'm well managed, and that population, if you will, represents just a real trivial value proposition in the overall scope of what I would call biologic cohorts, because there's little we can do about them except to sustain. The next tranche is the patient who has chronic comorbid disease but is not very well controlled or unaware that they have chronic morbid disease because they just haven't had a touch point into the health system. And that's where the greatest value proposition occurs. And I would argue in perioperative medicine, if we were going to throw our dart at the target, that's the bullseye that we have to really, really focus on, because that's where we're going to be able to most significantly bend that curve from a readiness for surgery point of view. And of course, the fourth tranche is people with just special disease. Those are the people who need transplants and have significant complex cancers and things like that. And there's a great margin of value proposition in that population as well. So with that said, I would say in the United States right now, because we've been victims of our own success, the journey from being declared surgical to surgery is a very, very flawed system. And in fact, this is a cartoon that outlines what that is. And anyone in any hospital in the United States would quickly identify with this. When that patient and that physician have that encounter and they make a determination or a contemplation that surgery is necessary, because we're in a widget kind of fee-for-service model, everything stops. We, do what we have to do to get that patient to the OR, because after all, that's where the gold is made. That's how you build those great, cathedrals of hospitals with granite waterfalls and things like that. And we've done some interesting things along the way. In the early 80s, we've sort of shifted from bringing people into the hospital the night before. Now we all have them, as day surgery patients, so we can condense that length of stay, and that's an efficiency driver. And we've certainly seen in the last decade enhanced recovery protocols, even squeezing that efficiency models down further. And those are all good things to do, but an unintended consequence of those efforts are that we've just not given ourselves enough time or focus to take care of those patients with the most need to have their chronic comorbid conditions managed proactively. And so what happens typically is we all have our pre-anesthesia clinics, and we scramble to get our patients in, because in the States we have a JCO mandated rule that they have to have their history and physical within a 30-day window, and they have to make sure the blue X is put on the left elbow and not the right knee, and we do all those clerical things, but we take inventory of the fact that they have poorly controlled diabetes, or they're profoundly anemic, or their nutrition status is not very optimized. We don't do anything about it. We sort of note that. We pass that information forward. We give it to the receiving team in the OR on the day of surgery, and they look at that, and they read the patient's history and physical and say, I have another sick patient I have to take care of. Darn it. I hate this. I hate my job. I hate my life. Why can't I ever take care of a healthy patient, for goodness sake? And then we do the best we can, because that's what we do. And then we stand up on podiums and we lecture about how sick people do less well than healthy people, and how well-managed people do better than poorly managed people. And we get invited to, wonderful locations like this to talk about that. And that's fundamentally unsatisfying, and we need to blow up that model. So with that said, we and a few other hospitals in the States, and this is real cutting edge for us in the States. As I mentioned, we're probably immature relative to the other speakers on the podium, with our recognition that we need to transform the sort of preoperative processes, or that determination of readiness for surgery. If you're a pilot, I always like to use the metaphor, you wouldn't land a plane unless the wheels were down and the flaps were down. You wouldn't think of that. Now, some of us would take great pride in being really good pilots, and if we have to land the plane, if the wheels are not down, we probably would be very skilled at doing that as best we can. But nevertheless, over time, you would argue that more planes crash and there are more adverse events if you don't routinely have the wheels down than if you routinely make that a part of your checklist. We're landing planes routinely with the wheels not down in the States, and that's a paradigm flaw. And so what we need to do is we need to get those patients much earlier, determine whether or not they're ready for surgery by their modifiable risk-adjusted criteria. We have to develop systems, and this is really, really important, for us to track the effectiveness and the efficiencies of that. And then we have to align our efforts with the overarching population health. The outcomes have to be defined in that much broader continuum. And so we've done that at Duke, and we've been sort of lauded for being on the edge with that. But there are a few other programs, and I think it's worth mentioning. The state of Michigan has a Michigan Quality Control Program where they've begun to do that. The state of Washington has something called Strong for Surgery where they've begun to do that. And there are a few other pockets in the states that have begun to do this, but it's very early in that curve. So what we've done, and I kind of stole this slide from Mike, but I improved it immensely, as we look at what can be done, what should be done, and what should be noted in terms of portending the risk of a patient for an adverse surgical outcome. And some things we do talk about in the science of perioperative medicine. Is it the right surgery? Or should there be surgery? Is it the right type of anesthetic? And what science do we need to better explore in order to define what is the right type of anesthetic? We're very, very nascent in that understanding. Of the socioeconomic considerations, I think those are equally very important for us as population health scientists to appreciate that. Just this quick anecdote. We have a program that we just looked at, 7,000 patients at chronic knee replacement in a Medicare program. And so we had this wonderful database, and we learned that the number one predictor of a 90-day readmission, irrespective of all other comorbid propensity match, the number one predictor of a patient coming back for a 90-day readmission was whether or not the patient was married. which is a surrogate for whether or not there's somebody there to take care of them after we work so hard to make sure their disposition strategy is not to a nursing home or a SNF or home. We have to think about transition to care in that respect. And then, of course, there are patient characteristics, and some of them are fixed and some of them are modifiable, and we have to be much, much more proactive to manage those modifiable risk factors. Now, these are some other data. I don't want to, but what this slide in summary says is we looked at these patients in this chronic need population, and we looked at a number of these modifiable risk factors: their nutritional health, their anemic situation, their diabetes, etc. And we compared noting that to a hospital that just wasn't in the program. And in fact, the length of stay in hospital was less, and their disposition inclination to be discharged home was greater. But as I mentioned earlier, their 90-day readmission wasn't. But the other thing that's really interesting from this slide is that although there were 15% of checklist violations, these significant severe modifiable risk factors in this group, only a third of them were actually proactively referred upstream to optimization program. And the point is, just noting that somebody has a problem is good, but it ain't enough. And we need to do something proactively about that. And so the last few slides, I guess, then are focused on what we've begun to do at Duke about that. And I like this saying, I hope you do as well, and it says, between data and intention is reality. And I think we've seen that a lot from Ross's talk as well. We look at data, we acquire data, we derive information from data all the time, and so we know what we should do, and we have an intention to do it, but we often never get there. And the reason I say between data and intention is reality is because if it isn't easy, we won't get there. And so system and process development is critical for implementation. Despite knowing what we should do, we often fall short of that mark. And so what we created at Duke is something we call the PASS Clinic. It's an acronym that stands for Perioperative Anesthesia and Surgical Screening Clinic. And the whole concept here, without getting too confused by this busy slide, is that we have made a great investment, years of convincing the surgical culture at Duke to change from where it was now, get them in a day or two before this clinic so we can check that box and move on, to having our surgeons now let us know the moment there is a contemplation of surgery that they send that patient to the PASS Clinic where we can do an exhaustive evaluation of their readiness for surgery. And frankly, most of the time they will be. But we've noted that about 18 to 20% of the time, people are just simply not ready for surgery. And what we do with those 18% is what is significant. And if we don't have the time, if we don't have the runway, if the surgeons are not willing to let us know as soon as they're thinking about surgery that we need to begin to define whether or not the wheels are down and the flaps are down, this wouldn't be effective. And so this is what we're doing, and this is the real cultural paradigm shift that's going on. And so we've developed in parallel a number of these optimization programs. We have a pre-operative anemia clinic. We have a pre-operative diabetic clinic. We have a pre-operative nutrition optimization clinic. We have a pre-operative clinic to take care of the geriatric population with their unique needs, et cetera, et cetera. And if we note, based on very well-crafted, re-engineered pathways, and we're talking about a bunch of people sitting around a room and just beating up ideas and looking at the data for hours and hours and hours and redefining and redesigning clinical care pathways. So each one of these programs is the expression of thousands of hours, including operations, including implementation science, including financial modeling. Then we send that patient, once we determine their threshold for tolerance is not met, to one of these optimization programs where they're attended to. We've created an IT structure where we're now looking at the planes that are circling O'Hare on a radar screen, so we know where they all are in the pipe, because we don't want to bring them in for a landing until we know they're ready. But yet you got to keep track of a lot of planes, and we built the IT structure to do that as well. And the idea is that when they're ready for surgery, they come in for surgery. Now, of course, urgencies and emergencies are dealt with urgently and emergently, but this is our paradigm at Duke. We've tightened up some things like our, phone screening criteria, and we've baked into that questions about pain, which is a huge endemic in the States. And we've also asked our surgeon, and that's the sort of yellow highlighted box there, a very important question that we heretofore never asked them. We asked them, if you send their patient to the past clinic, which we're expecting you to do, it's a mandate, if the patient's okay and ready for surgery, of course we would expect that you would have the opportunity to do the surgery on the day that you expect and wish to do the surgery. But if the patient is determined not to be ready for surgery, how tolerant are you? What is your length of time that you would be willing to delay that surgery until we can make that patient? And we absolutely mandate that every surgeon give us that answer. Now, the answer may be none for medical reasons that are, I think we have to be sensitive to. The answer may be we can't wait. I'm sorry the patient's not ready, but we can't wait. Or it may be 2 weeks, 4 weeks, 6 weeks, 6 months, and that gives us our sort of playing field to go do all these other things. And then, as I mentioned, we also have these systems that we baked in place to track that and give patients their little enduring tablets to make sure that they're on board, and we've hired people to hold their hands, and all that's important. So I will end with this slide, which is to say perioperative medicine in the States is a course of discipline that crosses over multi-disciplines, including surgery and anesthesia, and we do have geriatricians that are getting that space, but it's moreover a discipline that includes nursing and administration and finance, IT, and all the extenders. And so we've used that model to build our past clinic, and perioperative medicine is not just what we do to get that plane in, but also how we manage them in the OR. We talked a lot about enhanced recovery protocols here, and what we're also quite focused on is what do we do afterwards, and how do we transition their care back to home. Thanks.
TopMedTalk. Lee Majerison here. Thanks for listening to TopMedTalk. Now, before we let you go, it's important that we remind you to subscribe to TopMedTalk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out TopMedTalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. TopMedTalk.com, and click on the section marked email updates. Finally, TopMedTalk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. EBPOM.org is their website. That's EBPOM.org. And if you go to EBPOM.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on TopMedTalk. That's EBPOM.org/meetings.